Okay, so this is my lecture on cellulitis. It will be a long one. It's going to be important because you guys all have to treat a lot of this in your practices. So for our objectives today, we're going to be looking at the definition, the pathology, risk factors, complications, diagnostics, treatment, prognosis, prevention, and patient education. So let's look at the definition first of cellulitis. It's defined mostly by its presentation with redness, heat, pain, swelling, rubor, calor, dolor, tumor of integumentary tissue. It's sometimes you'll get all of those, and sometimes you'll get some of them. And if you get some of them and you're very suspicious of infection, go ahead and call it cellulitis. You can also have, it's also coincident with things like other cutaneous manifestations like folliculitis, impetigo, erysipelas, abscesses, and sloughing and necrosis of tissue. Those are not part of cellulitis, and they are not diagnostic of it. Moving on to pathology. Cellulitis is a manifestation of cutaneous immune response to infection. Most often, the originating part of the infection is an opening in the skin, but can also originate in other tissues. Cellulitis, it's always considered to be infectious in nature, but it can also be idiopathic. But you just assume that it's infectious. As the infection spreads, the borders of the cellulitis expand. As the organism overcomes the immune system of an area, it leads to other infectious processes, and those are the things where you see like abscesses and things like that, where cellulitis is just the body's response to infection. Moving on to risk factors. Most obvious is an opening in the skin from trauma, surgery, ulcers, dermatological disorders, and things like that. Impaired immunity, such as a pressure being applied to an area that overcomes circulation, vascular anomalies, vascular insufficiency. Pitting edema can also stop that, stop circulation. Compartment syndrome. Diabetes, we all know that impairs immunity. CKD, liver disease, HIV, cancer, chronic illness, these things all affect the immune system. And then spread is another important thing. It can be coming from other areas, such as from the bone, osteomyelitis. Abscesses can lead to cellulitis. Periodontal abscesses, ear, nose, and throat infections, and blood and lymph infections can all spread to the skin. Complications, those are an important part of cellulitis because you're treating cellulitis to prevent these complications. Let's see. As the pathogens destroy cells, white blood cells are brought over. As they're destroyed by bacteria, pus is formed. The immune system builds a cyst to wall off the pus, making an abscess. Larger abscesses generally involve hair follicles, and those are called furuncles, while clusters of abscesses are called carbuncles. Skin destruction mixed with scabbing and pus, it generally makes a honey-colored crust we know as impetigo. Super exaggerated cellulitis that is elevated, red, and very swollen is called erysipelas. It's a very serious group A beta hemolytic strep infection of the dermis and local lymphatics, and the lymphatics is what makes it all swollen. Necrotizing fasciitis is an aggressive infection with cytotoxins that rapidly destroy dermis and an aggressive and subcutaneous tissue, presenting with severe pain, bruising, bullae, crepitus, and necrosis. Osteomyelitis is an infection of the bone and bony support tissues. Gangrene is a progressive local regional tissue necrosis caused by compartment syndrome. So anything where the circulation is impaired, and you can end up with gangrene. This is caused by massive or circumferential cellulitis and associated destruction. Lymphangiitis is infection of lymph vessels, and it's the red streaks you see that lead out from points of infection. Toxicity is a big complication that we're going to be watching for, where an infection attacks the entire system and causes a systemic response. Presents with fever, chills, fatigue, malaise, aches, chills, and other things like that. Now, sepsis is severe toxicity that includes changes in hemodynamics, and this can often be fatal. So I'm going to show you a couple pictures here. This is a good example of a carbuncle. You can see there's several follicles involved in this. It makes a nice big cluster of swelling and pus. Here's impetigo. It's pretty classically presented in kids. See honey-colored crusts there. Erysipelas, you see this is really nice, big, swollen red, and it looks squishy. Necrotizing fasciitis. And if you see bruising associated with any kind of infectious process or anything like that, be scared, because who knows what's going on underneath. What's going underneath on this leg could very well be that hand just waiting to happen. Gangrene. This is pretty textbook here, death of the tissue. Lymphangiitis. You can see that going all the way up that lymph vessel, coming from infection at the wrist. Okay, moving on to diagnosis. So like I said before, redness, heat, pain, and swelling, all can be present, or some of them, and a significant suspicion of infection. Let's see, going on to history. Let's see. Most important elements of the history are the mechanism and the course of the infection. Specific organisms can be suggested by specific causes, like animal bites, a hospital stay or a surgical procedure, swimming in natural pools of water, they're butchering meats and stuff like that, and it's infecting a cut or something like that. Necrotizing fasciitis and other underlying diseases often reported as cellulitis that progresses rapidly or is strangely painful, so it should be treated aggressively. Also important are history of chronic infections, dermatological disorders, impaired immunity from chronic diseases like HIV, cancer, diabetes, CKD, or liver disease. Certain surgical procedures have higher rates of infection and cellulitis than others. Hip replacements, anything involving foreign bodies, liposuction, abdominopelvic procedures, procedures that resect or interrupt sections of the lymphatic system. So moving on to exam. Some peripheral things you look at, constitutional, you want to make sure they're not toxic. Cardiovascular, you want to make sure that they're not septic. Also, you're going to look at the vascular supply of the area. Pulmonary, just because you're being thorough. Extremities, you want to look for edema, because that can worsen circulation there, and it can be a manifestation of the disease. Let's see, moving on to exam of the integumentary system, you're going to want to ID any points of cellulitis, as well as ulcers, wounds, and other infectious processes, cellulitis, or necrotizing fasciitis, or anything goofy like that. The wound and cellulitis exam, you're going to annotate the locations, the dimensions, you're going to describe the wound bed if there is one, as well as exudate and if there's any odor. Labs and imaging. So firstly, if there is limited spread, there's no facial or joint involvement, there's minimal pain, they don't look toxic, they're not complicated patients, it's not from a weird source like going swimming or from a bite, and it's not a recurrent cellulitis or a resistant cellulitis, you don't have to work up at all. You just treat it empirically. Now, if it's a complicated patient, it's a recurrent or a recalcitrant infection. It's possibly an atypical bug. Get a wound culture if there is a wound. If they have severe signs and symptoms, it's diffusely spreading, it's deep invasion, looks like deep abscess or necrotizing fasciitis, God help you. Systemic signs and symptoms, it's associated with weird exposure like water or a bite. It's facial, or they have impaired immunity. Go ahead and get blood counts and a serum culture and sensitivity. If you're worrying about a deep abscess, or you think there's an abscess that you can't see, or you have to do a fine needle aspiration of an abscess, do an ultrasound. If there's bone involvement, or you think there might be bone involvement, and you say you can probe the bone, or there's recurrent wounds over the spot of suspicious bone, go ahead and get an x-ray and rule out osteomyelitis. Treatment. There's pharmacological treatment, there's non-pharmacological treatment, and then there's treating the underlying etiology. Let's start with pharmacological treatment. Antibiotics. Simple cellulitis is most often strep and should respond to dicloxacillin, amoxicillin, cephalexin, clindamycin, azithromycin, clarithromycin, or if you want to treat it aggressively, IM, ceftriaxone. Fluoroquinolones are best reserved for for sensitive gram negatives that aren't responding to other treatment. If the simple cellulitis recurs, you think along the lines of erythromycin or doxycycline for those weird bugs. If we're looking at rapid or painful cellulitis, you might have signs of toxicity. There's still usually a staph or a strep, and they can be treated by cefuroxime, cefazolin, nafcillin, ceftriaxone, oxacillin, vancomycin, or clindamycin. Bactrim and tetracyclines are not very effective against streptococci, so they should be reserved for purulent wounds. So if the more purulent, the more you start thinking it's a staph as opposed to a strep, and then Bactrim and tetracyclines will be more useful. Cellulitis with an abscess, furuncle, carbuncle, and severe purulent drainage. That's what you're thinking. Many regions of the country, clindamycin-resistant MRSA is a big problem, so check your area before you prescribe. Severe cellulitis is associated with purulence. You should go all the way up to, or expect them to go all the way up to ceftaroline, linezolid, tigecycline, daptomycin, or vancomycin, and you're thinking more inpatient treatment. We're working on some of the weird stuff. We've got bites. Amoxicillin or augmentin is first line. Bactrim plus metronidazole or a quinolone plus clindamycin is the other way to go for bites. So it's just easier to go with augmentin if you can. You'd be looking at inpatients getting like the papiricillin tazobactam or ampicillin sulbactam or fluoroquinolone with clindamycin. That's just what you'd be expecting, but you're sending them inpatient for that. Salt or brackish water associated with cellulitis needs fluoroquinolones or doxycycline with ceftazidime. And if it's fresh water, try a fluoroquinolone with a third to fourth generation cephalosporin, like give them some Rocephin or something like that. Okay, facial cellulitis. There's two different routes that you can get hit with facial cellulitis. It's either rooted in the eyes, the ears, and the skin around the face, or it could be from the mouth. So from stuff around the face, you're looking at Eikenella, Neisseria, or Group A beta hemolytic strip. Or if you're talking about the mouth, you're talking about Peptostreptococcus or Prevotella. The surface stuff, augmentin is good, and mouth organisms tend to respond well to clindamycin. Really severe stuff and periorbital cellulitis, ampicillin sulbactam is a quick way to do that. All right, pain, fever, APAP, NSAIDs, no problem. Non-pharmacological treatment. Cellulitis, to treat the symptoms, elevate it, cool compresses, maybe some compression. Some people tolerate that, some don't. But all that can help. With a wound, you know it's infected, so put an antimicrobial topical cream on there, or just some sort of antimicrobial like silver or something like that. Cover it with a dressing. Always cover it if it's open. Use absorptive dressings for exudating wounds, moisten dry wounds. Change all covering dressings daily and PRN while actively draining, and then as they dry up, every 3 days. Talking about abscesses, surgically drain any abscesses that are greater than 1 centimeter in diameter, or refer to a surgeon if you're not comfortable. Anything greater than 1 centimeter, so that's all abscesses that you're draining. Any openings that are 1 centimeter deep, go ahead and pack them. Change all packing every 3 to 7 days, depending mostly on the healing rate. Now, you're not going to be changing the packing every day unless you're reading every day or something goofy like that. Leave it in place. There's no benefit to unpacking and repacking daily. If it's healing more rapidly, go ahead and unpack every 3 days. If it's a slow healing wound, you can wait a week. Simple cellulitis, prognosis for that, oral antibiotics should be good. Should respond quickly and effectively in almost all cases. For really bad cellulitis, still you start an IV antibiotic, should be pretty quick and positive prognosis. Now, if things are extremely painful and rapidly progressing, you're looking at a really virulent group A beta hemolytic strep or a staph aureus MRSA or something like that. Slow conservative treatment can really lend itself to bad outcomes, sepsis and things like that. So you want to treat those extremely aggressively to make sure that they're not in danger. Okay, prevention. Treat infections in a timely manner. Cover open wounds. Avoid exposing open wounds to large bacterial burdens like going swimming, like especially in natural water. Working with raw meat with hand wounds. You got to make sure that you protect those with a dressing and gloves. Showering without covering all wounds below the level of the genitals and the anus, because they are going to get genital and anus water all over them, which is not the bacteria they're used to. Control diabetic blood sugar, hypertensive blood pressure, prevent decubitus ulcers, compress lymphedema and venous insufficiency, prevent dermatological disease flare-ups, and watch operative sites. Now we're looking at patient education. Patients should see their provider if they see signs of cellulitis, red, swollen, painful, warm, or an abscess. Patients should seek urgent care and elevate the extremity and take acetaminophen if they experience signs of severe or systemic disease, fever, chills, malaise, abscess with cellulitis, lymphangiatic streaking, white or diffuse spread, joint or face effect, or if they know they have a complicating disease, diabetes, etc. Patients should go straight to the hospital for the cellulitis if it's rapidly progressing or strangely painful because we fear necrotizing fasciitis, or if they feel woozy, palpitations, or know there's been a large change in their pulse or blood pressure because we fear sepsis. Okay, and that's the end of the lecture. If you have any questions, go get a book.